Well, welcome to today's talk. It's evening time, Wednesday the 27th of January, running a little bit late today. Now, I'm going to start off with some information from the Office for National Statistics, which shows that the clinical picture of the new variant, the new UK variant, is slightly different, in fact, reasonably different from the previous variant. Then we'll look at some news from the UK, the horrendous death rate, and from the United States. And I also want to give you some information from China as well, because the UK variant has now been discovered in several places, we believe, in China. So having gone from China to the UK, we've now mutated a variant, or it's been detected in the UK, and that's now migrated back to China. It just shows the international nature of this pandemic. But let's start off with this news from the Office for National Statistics. Now, the Office for National Statistics does a very sophisticated antigen testing operation in collaboration with Oxford University, and I think it's the Wellcome Trust, and is it Manchester University? I'm not sure. Quite a prestigious group of academics working with the Office for National Statistics doing this antigen survey, testing people for the presence of the virus, basically. And of course, that gives them the opportunity to ask questions as well. There's a lot of the questions go with the testing. So, Office for National Statistics, coronavirus infection survey, characteristics of people testing positive for COVID-19 in England. And this was just published on the 27th of January, today. So, antigen survey. Now, the spike gene is no longer detected in the current test. Now, this is just fortunate. So it just so happened that the test that we're using in the UK, it tests for 3 parts of the viral genome. And where there's a mutation, it doesn't show that bit up. So you'd think it might give a false negative, but it doesn't, because it tests for 2 other parts of the virus. So if it's the new variant, you'll get 2 positive areas on the antigen test, and the spike area will be negative. But if it's the old variant, all 3 will be positive. So it's actually really easy to tell the difference between the two variants from the standard antigen polymerase chain reaction test. So that was quite fortunate, really. And during this transition period where the UK has been changing from the old variant to the new UK variant, the B117 variant, that's essentially given us 2 groups, the old variant group and the new variant group. And of course, we can compare and contrast between those groups. So it's really been a natural experiment, really. So just fortunate that that's the way it worked out. Unfortunate that we have the variant. It's been a complete disaster, of course. But that's the way it's worked out, which is handy for the research purposes. Now, it talks about the classic symptoms that we know, of course: cough, fever, shortness of breath, loss of taste, loss of smell. So that's what it classifies as the classic symptoms. Now, new UK variant infections, more likely to report any symptoms. In other words, the infections were more likely to be symptomatic in any way. And of course, this means that there were less, the proportion of asymptomatic infections were that bit less. This could be good, because it means that people are more likely to know that they have the virus, therefore hopefully more likely to self-isolate. It's bad, of course, because it's 55% more transmissible, and we also believe it causes more deaths, perhaps instead of 1% death rate in men in their 60s, it goes up to about 1.3 or 1.4%. So it's quite a significant difference. But now it's also transpiring that it gives slightly different clinical picture. Now, the largest difference is there were more reports of cough, sore throat, fatigue, myalgia, fever in the new variant group. And they're also more likely to report the classic symptoms. So more symptoms altogether. More reports of cough, sore throat, fatigue, myalgia, that's the achy muscles, and fever, and more likely to report the classic symptoms, which are cough, fever, shortness of breath. Actually, they're not more likely to report loss of taste or smell. So that's where it varies slightly. So they were more likely to report those features, but significantly less likely, and significantly, when statisticians use that term, it means it's significant means that they're 95% sure it's a genuine result. Significantly less likely to report loss of taste and smell. No evidence of difference in the gastrointestinal symptoms, shortness of breath or headaches. Now, just to clarify this, let's look at the. I think we can look at the some data from this, which yes we can. So here we are. So this is the actual data published by the Office for National Statistics. The largest difference in reported symptoms between the new variant positive and triple positives, in other words, triple positives with the old variant, were found in cough, sore throat, fatigue and myalgia. So the new variant will be double positives because it doesn't come up for the spike protein gene. Triple positives are the old variant. Now, this is what they found. Now, percentage of people with symptoms by variant, including only those who have a strong positive test. That's right. So they only included people with a strong positive test, 30 cycles or less. In other words, people who had a fairly high load of the virus. So abdominal pain, so this is the new variant on top, the old variant on the bottom. Abdominal pain and abdominal pain about the same. Cough, new variant, more people with new variant and cough. Now this is 10%, 20%, 30%, 40% of infection. So we see about 35% of people with the new variant had a cough as opposed to about 28% of people with the old variant. Diarrhea, the difference wasn't huge between those two. But fatigue and weakness, more fatigue and weakness with the new variant, and more fever with the new variant as well. So we are seeing a different picture here. And going on to some other features here. Headache, new variant, more headaches. Loss of smell. The new variant, less people reported loss of smell. Loss of taste with the new variant in lighter green here. Less people reported loss of taste. But muscle aches, myalgia, more people with the new variant reported it. Nausea and vomiting, about the same. Shortness of breath, the difference here wasn't very great at all. And sore throat, more people with the new variant reporting it. So what we're actually seeing here is really a somewhat different presentation of the disease, really. So I thought that was that's certainly interesting. So to summarise, the new variant is about 55% more transmissible, perhaps about 30% more deadly compared to the old variant, and it makes people sicker, and it makes people less likely to report loss of taste or smell, but it makes people more likely to report any symptoms. So we are dealing with somewhat of a different complexion here. Somewhat of a different complexion with this new variant. If I can get my technology right, that's what I need in a minute. Right, let's get back to the UK now. Cases in the UK still reasonably high. I think I'll just show you the data from the COVID symptom tracker app, which we should have here. Yes. So quite a lot of new symptomatic cases in the UK today, actually. This is not good. We're still at a fairly high level. We are going down. This is the prevalence, the number of people with the infection now going down. It's going down nicely, but it's still well over 500,000 people with the virus in the UK today. So it's quite easy to talk about numbers going down, but they're still high. Now, the UK, 25,000 new cases officially reported last 24 hours, 3.7 million cases reported altogether now. Hospitalisations, another 3,000 people admitted to hospital. Now, this is still hugely high. This is still incredibly high. Dangerously high levels of hospitalisation still throughout the UK as a whole. And if we just look at the official data, actually, we've got the... So we see the numbers on the official cases are going down quite nicely, but still at a fairly high level, it has to be said. But going down but at still a fairly high level. But if we look at hospitalisations, Yes, the new hospitalisations are starting to go down slightly, but this bar is still incredibly long. There is still an awful lot of people being hospitalised every day, and a lot of people still in hospital, and a lot of people here still in intensive care. So, encouraging signs in reducing cases, not feeding through to hospitalisations, that's significant, really. And of course, the big news in the UK has been the death figure. There's no getting away from this. This was the deaths last 24 hours. This was the deaths of 24 hours before that, and we've passed the 100,000 death mark yesterday. So really quite horrendous death rates in the UK. 100,000 people died. These are people dying within 28 days of a positive COVID-19 diagnosis. Now, I'm always getting people saying, look, someone could test positive for COVID-19, then get hit by a bus and be counted in the statistics. Well, that's true, but the probability of being hit by a bus in the 28 days after being tested aren't that high. So the vast majority of these deaths are attributable to COVID-19. And the number is really quite horrendous. Easy to talk about numbers. If we can see the deaths on the graphics here, we do see a decline, but a very gradual one. In fact, that's just a levelling off on that one. Deaths within 28 days of a positive reported test. So no getting away from it. This has been a complete disaster. This is deaths on the death certificate, always slightly more. This is probably the more accurate number. That was the number of new deaths recorded on death certificates in the past 7 days. And the deaths will come down slowly because of this big delay effect, because we've had so many cases lately. These are baked in now, that these deaths will occur. Professor Chris Whitty, Chief Medical Officer, a lot more deaths over the next few weeks. Basically, you put that out as a statement. There's going to be more deaths over the next few weeks. Before the effects of the lockdown and the vaccinations kick in. And he says current restrictions just about holding lower number of infection rates. Well, they are going down, but this is with quite a significant, not really sustainable degree of lockdown in the UK. That's keeping these figures where they are. Now, what I like to do is compare, if we have the picture. Yeah, we do. So I've just taken this from Our World in Data, and the cases are coming down in the US and in the UK. But we know the numbers are coming down in both countries. But we know that the UK decline is caused by the severe lockdown that we have, whereas the lockdown in the US is not as significant. But it is really quite uncanny the way that these graphs are just mirroring each other so closely. This is pure coincidence. But I'm worried that the United States one's going to rebound with the new variant, and I'm also worried that Canada's going to rebound with the new variant. And while we're talking about the new variant, let's spare a thought for Portugal, where the new variant has really taken off the UK variant. We believe this is mostly UK variant effect. And we hear that hospitals in parts of Portugal are overwhelmed, and there's considerations for trying to ship some patients or fly some patients to Spain. The situation's bad. One hospital did run out of oxygen for a period of time, but it was quickly fixed. But they are in a really quite a desperate situation in Portugal, and let's just hope their restrictive measures are we starting to see a slight levelling off there? Let's hope so, because at the moment there's a lot of people dying, and there's a lot of people struggling to receive healthcare in Portugal at the moment. And of course, because these numbers have risen so high, that inevitably means the deaths will follow. The deaths will stay high in Portugal for the next month. I'm afraid that is a guarantee. So that's some things about the new variant and the effect, and the deaths that are still going to come. So 100,000 deaths now. How many more are going to come? I'm not going to start guessing numbers, but it's going to stay high for the next month and then only come down gradually. Vaccinations in the UK, down a bit over the past couple of days, but 7.1 million. Second dose, we're not really going for that at the moment. That will start in the next week or two, getting on for 500,000. Prime Minister's talking about English schools going back on the 8th of March. That'll probably be the first thing that's happening. So the reason I put that in was the fact that the Prime Minister said the 8th of March for schools. Now, he's agreed to prioritise schools. So I think we can assume that pubs won't be open till sometime after that, or restaurants and all the other things. And of course, the UK government has realised the risk of new variants now because of the devastating effect the UK ones had, and we want to keep the other ones out as well. So new restrictions announced by Priti Patel, the Home Secretary, this afternoon. Quarantining in hotels for 10 days at the individual's own expense from 30 high-risk countries. Trouble is, the 30 high-risk countries, the countries that that are known to have new mutations are the ones with good testing. The UK's testing, we test, in the UK we do about 45% of the whole world's genomic testing. So we pick things up, whereas there might be countries with significant problems, and I'm afraid the United States could be in that category, who simply don't know because of limited testing. So people are going to be met at the airport, transported directly into quarantine. 30 countries, obviously South America, South Africa, Portugal, various other countries. And no one from the UK is allowed to travel for leisure. That is completely forbidden at the moment. So no one is allowed to go abroad on holiday. Now, thinking about the United States now, here's the United States graph. And we do see that the cases are going down nicely, but they did in our country, in the UK, before the new variant started kicking in. So 7-day moving average there, 168,000 new cases per day. I mean, it's still a horrendous figure. That's quite out of date now. So hopefully that's carried on going down. But the deaths in the States are stubbornly high. So averaging 3,414 deaths on the 7 days up to the 23rd of January, so 4 days ago. So cases going down, deaths remaining high in the States. Past 7 days, cases are actually down by 16.4%, according to the Washington Post, so that's good. Deaths are unfortunately still high because of the lag effect from the cases from 3-4 weeks ago. Hospitalisations, now in many areas of the States, hospitalisations are still really quite critical, but nationally it's down 10.4%, so it's a good trend. US national positivity rate 9.1%, 5% is the epidemic threshold. It's down from where it was, but it's still high in the epidemic range. Vaccinations in the States, mostly Pfizer. I think it's about 55% Pfizer, 45% Moderna, roughly, in the States, Moderna. 43 million doses given, completed courses, 3.5 million, that's 1% of the population. So good, but a lot to go. Now, yesterday we learned that President Biden was hoping for 1.5 million doses a day. He seems to have revised it down now to 1 million doses per day. So it's looking like the United States is on track for that 1 million doses per day. And yesterday was perhaps somewhat over-optimistic. Now I'm going to do a brief report now from China. The first one is the use of anal swabs. Now, anal swabs is a potentially optimal specimen for SARS coronavirus to evaluate hospital discharge of COVID, patients. In other words, it's in the later stages of the illness. This is in Future Medicine, it's published. So now the Ace2 receptors, the background science here is the Ace2 receptors, where the virus fits into, of course, are most abundantly expressed on the surface of the alveolar epithelium. You know, remember the alveoli are these microscopic air sacs in the lungs, where the oxygen goes from there into the blood. The carbon dioxide goes from there back into the air to be breathed out. And when there's acute respiratory distress syndrome, these fill up with fluid and patients essentially drown. That is the nature of that inflammatory problem. But this epithelium, this lining around here, is high in the Ace2 receptors. But so are cells in the small intestine. The epithelial cells, the enterocytes lining the small intestine. So there's a lot in the intestine as well. And it seems that typically people shed virus from the upper respiratory tract in the early stages of the infection, then from the lower respiratory tract, and then from the gastrointestinal tract. Kind of in that order, really. That's what this paper's saying. Different phases of the infection. So beta coronavirus, which of course SARS coronavirus 2 is a beta coronavirus. Genus, that just means the grouping, can cause respiratory, intestinal, liver and nervous system infections in animals and humans. We've known this for years. So this seems to be the order. So first upper respiratory tract infection occurs, therefore upper respiratory shedding. Then lower respiratory tract infection, therefore lower respiratory tract infection. But it can also get into the blood. The viruses can get from the lungs into the blood and travel around the body. Now, this is called viremia. But the amount of virus found in the blood, thankfully, is pretty low. It's not a significant viremia. But then fourthly, goes into the gastrointestinal tract. Now, I suppose the gastrointestinal tract could be purely infected, because if you've got infected sputum from your nasopharynx and your oropharynx and your chest, you're going to swallow it, and that can infect the gastrointestinal tract. So that's going to feed through into the stools, and that's why anal swabbing can be useful in the later stages. So this is going to be particularly useful for recovering patients. So people can continue to test positive days after nasal and throat swabs were negative. So people can be testing positive with anal swabs even after they're testing negative for oropharyngeal swabs. Now, it's pretty inconvenient taking anal samples. You have to use an implement and go a couple of centimetres actually into the anal canal. So it's inconvenient process. So it's probably going to be done mostly in quarantine centres, assessing people prior to release from quarantine. But it will raise the rate of identifying infected patients, because a few patients, not many, but a few, actually test negative for oropharyngeal swabs, but then test positive for anal swabs. So it could well be another useful tool in monitoring the course of the pandemic. And we've been doing this sort of thing for many years in clinical practice. This is nothing new. Now, domestic travel in China could kick off next month for the Lunar New Year. Interesting to see if the Chinese authorities clamp down on that. Probably, I suspect they may do, because of the UK variant, which is now in China and is a significant threat to China, 55% more transmissible. Low cases at the moment. There was a student went back in early December, was diagnosed and caught in quarantine. But if people are flying around and then someone arrives in China in the early stages of the infection before they're testing positive, then they could potentially spread this. I mean, I think the Chinese are seriously strict on the quarantine, but there have been a few cases escaped, we believe, and we believe there are some clusters in Beijing, of some clusters that are being isolated in Beijing of the UK variant. Although, as we know from previous experience, news from China can be ambiguous. Travellers arriving from overseas in China, 2-week quarantine hotel, so they are strict. 3rd week of home quarantine and a 4th week of daily reports. So hopefully that should catch them all. But even that, it seems that 1 or 2 have escaped, and we believe there are some clusters at the moment. Clarity will come on that soon, I would hope. Now, shall I mention this? Yeah, I'll mention this. Very undignified statement really from the European Union today. So the background to this is the European Union, Oxford AstraZeneca vaccine. Now, they haven't approved it yet. We suggested they approve it about 6 weeks ago on this channel. They haven't approved it yet. They say they're working night and day on this. Well, the UK Medicines and Healthcare Regulatory Authority managed to work it out a long time ago. Why the Europeans are so slow, I don't know. But they've ordered 300 million doses with an option on 100 million, so that would be good. But there's production delays in the plants in Netherlands and Belgium. 2 months behind. I mean, this is devastating delay in production, behind hoped for figures. Now, the UK signed to get its Oxford AstraZeneca vaccine from these plants in the Netherlands and Belgium, as far as we know, in May. And then the European Union decided they'd have some in August. So they were a bit behind the game. You would have thought that the European Union authorities in May would have realised they have a pandemic by that time. Why weren't they more proactive on vaccination? They're clearly embarrassed by this now. And they're now, looks like to me, they're trying to... Oh no, politicians wouldn't try and shift blame, would they? Silly of me to think that. Anyway, 80 million doses expected by March was the expectation, but that's reduced to 31 million. Now this is devastating, a 60% reduction in the Oxford AstraZeneca vaccine. And they're stomping their feet and threatening to stop exporting vaccines from the European bloc overseas. It's diverting attention away from their what I would consider lack of proactivity. It's all quite undignified. It just shows you just have to. Actually, I was going to say it's about restricting a resource and people start fighting for that resource. I think this is more political. I think they're more trying to hide their embarrassment, but we won't say any more because we don't want to be political. But that's what's happening, and the bottom line is all I'm interested in is people's well-being. That's all this is about. And a 2-month delay is just tragic for the people of Europe. Absolutely tragic. But they didn't order the vaccine till August. Go figure. European Union, Pfizer, they've ordered 600 million doses. That's produced in Belgium as well, actually. The Pfizer BioNTech. Very awkward, all this transporting at minus 70 or 80 degrees centigrade, whatever it is. Now, even then, the supplies from the Belgian factory are delayed, so there's delays there. But this is good. Sanofi, French group, will help produce 125 million doses of the Pfizer BioNTech vaccine in their Frankfurt plant. But they can't reorganise that till July. And again, very, very slow off the blocks here with the European authorities, really. Why weren't they negotiating this months ago? Would be the question that I would ask. So I suspect there's going to be some pretty unpopular politicians in Europe. Anyway, let's look at the progress of vaccines around the world. Now, we'll finish with this today. Canada, again, disappointing. Supply issues mostly. The States, well, this is the total doses given. So 6.2% of the population got at least one shot. So they're protected from most of them are now protected from getting sick. If you look at countries like France, I mean, 1.8 doses given altogether. Portugal, where things are absolutely desperate at the moment, fairly poor. So frustratingly slow in the UK as well, really, but slightly better. In places like China, you'd think they'd be well on, but they're not. 1.1% of the population. Not impressive. I'm surprised the Chinese haven't done more. Things are starting in India. Leading the pack, we've got United Arab Emirates. Where are they? 25% of the population. Wow. Given at least one dose. Impressive. Smaller population, of course. Bahrain also doing very well, 9.7. I think Israel's probably still leading. Wow, 45% of the population. 30% of the population given at least one shot. And we looked yesterday at some interesting data that's coming out of Israel, because that's going to be the first country to deliver full data sets, which of course we look forward to, because that's going to inform how the whole world vaccination program rolls out. I've completely lost track of time today. I've no idea if this was a long one or a short one, but I think it was longish, so I'll keep some pictures for another day. Okay, so that is us for today. Thank you, of course, for watching. Always good to communicate.